part of our academic series, which lies to look into latest evidences with regards to pediatric endocrinology. And as we know that every year there are around over 1,20,000 articles which are published across the globe. And if we do not keep pace with them, we will get left out. And very important to understand that when we're looking at those articles as to how it should change our practice in a clinical sense. So why do we need to do a literature review? And what we are looking at in terms of literature review is that we want to see whether the journal article that we are reading should be part of our clinical practice or not. So the key questions you will ask is whether the results that the article has published are really valid. Very importantly, they may be valid, but whether they are generalizable to our settings or not. So if you look at some data with regards to 780G, which shows that there is a significant improvement in terms of diabetic outcome, but if your patient cannot afford it, then it may not be generalizable to your clinical practice. We also want to see whether that journal article really represents a new development or it is an incremental phenomena. So whether it is a 0 to 1 or a 1 to 2 sort of activity. So you want to say that if it's 0 to 1, then probably this is something which is path breaking and things will change over time. And ultimately the aim would be to change your practice from that regards. All of you can go and have a look at our website, learning.growsociety.com, in which has got a lot of resources and courses related to pediatric endocrinology. We have got fellowship and postgraduate training programs. We do run a number of postgraduate lecture series. We also run the journal clubs and guideline reviews. Publications are available along with our mobile applications.
The safety and efficacy of the denosumab in the children in osteogenesis imperfecta. So this is the paper which was published in JCEM in 2024. The study has been done in China, and probably it was the first prospective comparative study using zoledronic acid as well as the denosumab and the comparative assessment regarding that. We all know that osteogenesis imperfecta is an intrinsic bone disorder involving the collagen, and this osteogenesis imperfecta usually causes various bony deformities, scoliosis, increase the fragility fractures in the children, as well as also some extra osseous manifestations like cardiorespiratory manifestation, loose sclera, dentigerous imperfecta. The incidence is like around 1 in 15,000 to 1 in 20,000. The major treatment protocol that has been used till now in osteogenesis imperfecta in children were bisphosphonates. There are two groups, usually in oral therapy, which is used in case of mild osteogenesis imperfecta, while the IV therapies or IV zoledronic acids were used in cases of severe osteogenesis imperfecta. Now, why do we need to have this denosumab to use in these cases of osteogenesis imperfecta? There has been shown that the bisphosphonates have very inconsistent effect in terms of fracture reduction, especially the fragility fractures. That means that in the minor trauma, there is a fracture in the bones. This has been a meta-analysis that has been published, and it is showing the osteogenesis imperfecta. If you use bisphosphonate, the bone mineral density were improved, but the prediction of the fractures were not consistent with the bisphosphonate therapy.
So is it because there are limited number of controlled trials?
Probably, sir.
Meta-analysis of only placebo-controlled trials.
Yes, sir.
So do you think there are a lot of placebo-controlled trials which are available with bisphosphonates?
I think the trials number was not so much in terms of.
Do you think it may be justifiable to have a placebo-controlled trial now in the setting that if you know that there is a therapy with whatever questionable logic is, they will improve the bone density, whether you will be justified in using one arm in which there is no treatment given?
No, I don't think, because the severity, if we see in
this is a catch-22 situation.
Yes.
Suppose denosumab was the first compound and you know that it improves BMD, you cannot have ethically an arm which does not have any treatment at all. So that is the problem, I think, in that perspective. Otherwise, if you look anecdotally, it is going to be a much. So I think what would be a better design in these sort of scenarios?
Superiority or non-inferiority between two available treatment options.
So there is only one available treatment, which is bisphosphonate. What do you do? You can go by historical controls. So what historical controls used to have and how many fractures will come? So I don't think there will be a lot of randomized trial
Trials,
data.
yes.
So just because you say that there is a lack of evidence does not mean that there is no significant
yes.
difference, because that is where it being used a lot.
And also, our study, it has been a comparative study. We're not using only Denosumab in this study. So we can also see whether the bisphosphonate is better in terms of using, in terms of Denosumab. Also, there are some severe adverse reactions like fever-like reactions, flu-like reactions in case of IV Zoledronate, where in cases of oral agents, the gastric irritation, gastritis-like events were much more. Also, we all know that the osteogenesis imperfecta is mainly initially classified by Silence classification, and it was 4 major subcategories considering the collagen disorders. But later on, there are some also autosomal recessive and X-linked varieties are there, the special types of osteogenesis imperfecta with advent of the NGS and the other genetic studies, which was not properly or well controlled by this bisphosphonates.
What, according to you, this is what they have written. According to you, what are the limitations of bisphosphonates? When you want something new, you want to know what is the problem with the old one. So what is the problem that you have with the old treatment?
Sir, if we comparison with the placebo and some, but
no, I'm saying that if something is going perfectly fine, if you say your thyroxine is doing very well in hypothyroidism, you just don't have another agent, levothyroxine, you start using some other alternative form. You have to have some reason why you want to alternate. What is your thought process on that?
In terms of bone mineral, I don't think bisphosphonates are much lesser, much important.
Anything else? That's what I'm asking.
The IV, the need
to
of
give IV
injections,
the risk of having hypocalcemia, the risk of having high-grade fever, especially with pramidinate needing multiple infusions on days, these are the limitations. So that will be a more important limitation on that.
So in these trials, who has been taken as the study population? This is the children with adolescents younger than the 18 years of age with, we had confirmed with one of the following inclusion criteria. The inclusion criteria are in 3 stages. If the child has a pathogenic gene mutation that is detected by NGS or Sanger sequencing, if they had a family history of Y with associated features like blue sclera, dentigerous imperfecta, or they have at least one fracture with minor trauma. Now, they have described this minor trauma by that if we have fracture when we are doing the daily activities or fall from the height that is lower than the sitting height. In that scenarios, these children has been included in this study.
What means is that even if they have just one fracture and their Z score is less than -2, you will assume that they have osteogenesis. Because you don't have any other clinical features, you don't have any genetic diagnosis.
But at the same time, you have to think that, sir, this is due to the minor trauma. With minor trauma, if there is fracture,
any pathological fracture, you will say it's OI.
No, we will not say this is why.
This is what the diagnostic criteria is suggesting. Because if you go by your listing, any one of them, history of at least one fracture under which is a pathological fracture, single pathological fracture, then and Z score is less than -2, you say it's OI. You're assuming every low bone mass is OI.
This paper has.
So this is one. So this is how you have to critically look into it. Carry on.
They had also excluded some children in whom BMD cannot be measurable at the level of the femoral neck, lumbar spine, or hip. Also, the patients with renal failure, and also any current treatment protocol that causes this inhibition of the bone resorption that could bias the result of this study has been excluded from this study.
It doesn't even exclude the other possible causes of low bone.
Yes, sir.
So these would be part of the limitation that you have to start off right away. So when you look at the article, you have to look what are the issues to go ahead. How did they define OI? But at the end of the day, you're not talking about low bone mass in children. You're talking about osteogenesis imperfecta as a specific trial. So that becomes important. Can you?
Now,
2 and 3. So either you can say 1 plus 2 or 3.
Yes, that could burn me. Yes, sir.
So that will become easier one.
Now, this is an open label randomized controlled trial having 84 children they had been divided into two groups. One group is Denosumab group, that is consisting of 42 children, and another group is zoledronic acid group, that is 42 children. And they had done 6 monthly and 12 monthly follow-up for a 1 year of duration.
But before you go ahead, you should say what is the advantage of Denosumab for people who are not aware about that over zoledronic acid.
Yes. So Denosumab is a RANG ligand inhibitor. So when we are using this, it inhibits the bone resorption in that scenario. Also, as we all know that bisphosphonates are getting deposited in the bones and staying there for the long time. Denosumab is a short-acting agent, so it will not cause much harm when we stop the treatment of the Denosumab. As well as Denosumab is given 6 monthly duration with a subcut injection.
That is the biggest advantage, that you have a subcut injection not requiring hospitalization.
Yes.
That would be the biggest one. Now, what you said that it is not deposited in the bone and has a shorter action, whether it is an advantage or disadvantage is a open case. You cannot say that that's an advantage. So I think the biggest reason why adults are moving towards that is that you have to give subcutaneous injection once in 6 months. So carry on.
So in the 1 year of follow-up, the Denosumab group has discontinuation of 11 children, where there is only 2 discontinuation in the group of zoledronic acid, and among these 11, there is 6 patients who are discontinued due to the hypercalcemic crisis or hypercalcemic like episodes are there. Now, if we see the baseline characteristics in this study, the male-female ratio was 2:1 in both the arms. The mean age of in the both groups were very much comparable in that scenario. If we see the anthropometric measurements, also they are comparable in both the groups.
So why have they not given p-values to compare the two? So when you actually have a good randomization, you don't need to show that the p-value is not significant. You assume your randomization is there and you don't even need to look. It's just that if you find a bias, you can look at it. Otherwise, you assume that there was a proper randomization here.
Okay.
What do you see particularly here, which is not similar to a typical OI cutoff cohort? What is unusual here?
The BMDZ scores.
So you said BMDZ score is, where is the BMDZ score?
So not significantly lower in cases of lumbar spine actually.
There are 2-3 big things that we're looking at. One is the age. What is the usual age of presentation of severe OI?
Very early onset.
So it is very infancy. So it is very, very unusual that your age is 7.35, 7.5. So these are very, very late. So it may be either they are taking milder cases or whether these, and were these cases treated earlier also with bisphosphonate or not?
Yes, they were treated.
So this part, so they have not excluded patients who were not treated. These are not drug naive patients. Number one. And number two, what you're seeing here is that they are older. And now if you look at the BMD-Z score
of lumbar spine, it is not so less as in comparison to the osteogenesis imperfecta. -1.5 and minus.
But your first criteria is less than -2.
Yes.
So that is the whole problem in the criteria. So one side they say low bone mass and fracture is OI. Second they say they just have a eye sign and they don't even have fracture, they are OI.
Yes, there are no fractures, but only family history was present there.
So this is like in a very, very dichotomous population, which means if you have loose sclera and you don't have a fracture, your bone mass is +2, you are still OI.
They assume that they are OI actually.
Yeah, so that is a problem I would say in terms of the inclusion criteria. And that's reflected, which you also pointed out, is that if you look at any of these Z scores, you maybe femoral neck Z score is on the lower side.
Yes.
That is there, but otherwise the BMD Z score is not exceedingly low. So I think that is something which is important. Now, if you look at previous fracture times, which is 4, which is reasonable. Okay, and 14 and 19% had used bisphosphonate.
Bisphosphonate, yes.
This figure becomes important. Why? You yourself said that if you use bisphosphonate,
There is increased risk of fractures will be much more.
they would be there for a long time. So it may be interfering or it may be augmenting the effect of other therapies.
Yes.
So this is something you have to worry about, carry on. But of course, if you look at that way, you've got 42, 80, 4 patients of OI, it's a big number.
Yes, sir.
So you have to think of that it's a good study, but then you have to think of what could be the thing which can influence the results also.
Ideally, on the genetic study, we should be confirmed the genetic study.
It
Then
should have been, if you ask me what should be the criteria, these will be drug naive, novel patients of OI, diagnosed, confirmed using genetics. Because when you're doing so much, you should be very, very clear that they are there. And then those OI patients must be candidates for treatment. Just having the gene and your bone density is in the normal range doesn't mean that they need to be treated. So a drug naive new patient who is genetically proven, who has a pathological fracture. That should be done.
In the genetic study, they had done almost all the genetic study in all the patients. And in Denosumab group, 8 patient doesn't have any significant mutation of the OI.
Yeah. So
and in 4 in zoledronic acid. So total 12 patient were there who doesn't have any.
Their first criteria is very vague. Second criteria is also vague. So I think that's okay. Let's go forward on that. So what they're basically saying is that there is a milder form of disorder that we are seeing at, and these are older children and they have received treatment.
Yes, sir.
So these things you have to take care of. Yeah, carry on.
Now, coming on to the first primary endpoint, that was a comparison of the BMD, aerial BMD, in cases of both Denosumab group as well as the zoledronic acid group. It has been seen there is an improvement of, and that is a significant improvement of the BMD in both in lumbar spine, femoral leg, as well as total hip from the baseline in 12 months duration.
What statistical tool did they use to find this difference?
Statistical tool.
Which one will you use? If you have same person and you are seeing in 3 months, 6 months, 12 months, this is what you're doing. So which tool will you use? Yes, analysis of variance, not pair, one way ANOVA and two way. So ANOVA would be repeated measures ANOVA is what you will be looking at. So this will be ANOVA sort of a test you're looking at. Carry on. So what you are seeing is that there is improvement.
Yes.
In terms of density.
In terms of density, there is improvement in the from the baseline.
How long are they following up for?
They are followed for 1 year. Total.
Only
1 year.
It is 2 less, but yes, okay, you're finding a difference. Carry on.
And also they had seen, if we compare both the groups, the zoledronic acid group and the Denosumab group, the zoledronic acid group has a significant higher bone mineral density from comparison to the Denosumab group.
Okay, so yeah, so both groups are there. Okay, and carry on.
Now they compare the secondary endpoint there, that is the biochemical profile of the bone metabolism indexes, and they had shown that the calcium level was much more higher in comparison to the baseline after 12 months of treatment with Denosumab, but there was no significant change of calcium level in cases of bisphosphonate therapy. Also,
it went down a bit.
But I think there is some mismatch with the color coding with Denosumab and zoledronic acid in this study.
Okay. Now, do you think this is a good way of showing the calcium results?
I don't think, sir, this is a good way because this is only a 6-month study, 6 months
What are you more interested in? The average calcium or how many are hypercalcemic?
Ideally, it should be how many are the hypercalcemia.
So if you could have shown the distribution that these percent is normal, it's like you say time in range, time below range, time above range. So calcium in range, calcium below range, calcium above range. That is more important. Because if your calcium, somebody's calcium is 20, he will drag the entire graph toward the upside. So this is not a very most important thing to look at, but yes, you can here also see.
But sir, also we can see the baseline to the
that there is a wide skew in the calcium level in the Denosumab group, because those who have more calcium, few individuals are dragging it away on the other side. But the mean value is not that high.
That high, yes.
So yeah, so what you are saying is that there is different differences in calcium. What about other parameters?
There is a decrease in the bone resorption markers, that is beta CTX level, and also there is a significant change of ALP level, both in the zoledronic acid group as well as the denosumab group.
So they have come down.
They have come down.
ALP level has come down.
ALP level has been come down. Now, the one more important thing here is that there is much more incidence of hypercalcemias, and 6 patients almost
that
having.
Is most important. That's what data you want.
Yes, the hypercalcemia was after the discontinuation of the denosumab therapy was done, and it was 13 in numbers where there is no episode of hypercalcemia in cases of zoledronic acid group. And among these 13 patients, 6 patients were critically ill. They have to admit in the hospital.
So
for
when
the
you say
treatment.
Discontinuation, it means was it even after the first injection, second injection, or after the third injection?
Even there is only 2 injections given, 6 months and 12 months. After the 12 months,
0 in India.
3 injections total, 0, 6 and 12 months. After the 12 months injection, the mean duration was 4.7 months after the first hypercalcemic episode has been noted.
So the hypercalcemia happened after you gave the
third injection. Yes.
And after 4 months.
After 4 months. Mean
so what I'm asking is that, did it happen between second and third injection and first and second also?
There is no such data about that.
6 months, it is within that therapeutic period. So it should not have happened, because by this time the denosumab should be working. So do you have the timeline for that?
No, sir, I don't have any timeline.
Okay,
but sir, one more thing important, that the duration was 6 monthly interval, and I am saying that after 12 months, after 4 months, the mean age is 4 months. So even if it happens, it should be happened between in the 0 months and 6 months, or 6 to 12 months.
Yeah, after 18 months. Hypercalcemia, if at all this rebound effect should be happening after 18 months. Now, first of all, why does denosumab have a rebound hypercalcemia?
Because this is very short-acting molecule. It acts on the rank ligand. When we taper it off, there is no effect present, and there is increased bone resorption started.
Bisphosphonates not only stop resorption, they also kill the osteoclast.
Yeah.
It has got no effect on osteoclast. So osteoclast gets suppressed, but they are not killed. As soon as you remove it, they will surge again. But as you said, the effect should be at least there till around by the time denosumab is there. So this 16 months seems to be a bit of a concerning thing, which means that in younger age group, the 6-month period is not good enough to provide enough suppression, because maybe the rank ligand activity is more, its recovery is better than your 0 to 6. 6 to 12 also may be a risk of hypercalcemia.
They had pointed out the similar thing, and they also mentioned that the dose of the denosumab they had given to the hair, it's not on the weight-based dose. They had given above 5 years 60 milligram, and less than 5 milligram 30 milligram denosumab. Huge dose. And also, sir,
60 is for adults.
Yes, they have used that dose, and due to they have said that if we use the weight-based dosing formula, maybe that we could prevent this kind of hypercalcemic episodes. Now, they have also looked for the vertebral morphometry, or the risk of spinal compression fracture, and they have seen that the average projection area as well as the ratios of mid height versus limb length, lower length ratios were improved in both the cases of denosumab and zoledronic acid, but it is significantly improved in cases of denosumab group.
But you have to tell us what is the meaning of this.
Yes. So they had now I first describe how they have taken.
What is the meaning of these values for a patient? Are you happier with a higher PA value or a lower PA value? What does it mean?
If the PA value is higher, the projection area is higher, there is less concavity. This is concavity index basically. So there will be less compression, less chances of fracture, spinal compression fracture, and increased chance of height gain also in that scenario.
That is what we could point to that. So there were vertebral benefits in both possibly more in the case of Denosumab.
Yes. Also, they have seen the height gain in these children, which was almost comparable in the both group, 5.6 versus 5.7 centimeter, which shows that there is no incidence of any vertebral fracture or in this scenario. Now, in comparison to the adverse effect, we have the zoledronic acid is known to cause various febrile illness, which is very much prevalent in our study also. There is 30 patients that has been presented with acute febrile illness. But when you compare the hypercalcemic episodes or the hypercalcemic crisis, the denosumab group has much more hypercalcemic events in comparison to the zoledronic acid. And the interesting thing about this thing is that there is no episodes of hypercalcemia seen with this case of zoledronic acid. Even the patients presented with hypercalcemia also treated with hydration and zoledronic acid, who were subsequently normocalcemic for the 1 year of duration.
So what do you expect with zoledronic acid? Hypo or hyper?
Not hyper, hypo.
If at all, if you have a low amount of calcium status, you will develop hypo. But hyper, it's a treatment of hypercalcemia,
yes.
So you will not expect hypercalcemia there. Yeah.
So they had concluded that the treatment with denosumab have significantly changed the bone mineral density as well as decreases the risk of spinal fracture in cases of pediatric population with OI, and the effect is almost similar to the zoledronic acid. Though there is increased risk of adverse effect in these cases of denosumab group, they had concluded that the younger age and the high bone resorption markers in patients who have younger age less than 5 years of age and high bone resorption marker, they have much more risk of hypercalcemia rather than the rest of the group.
And the irony is that they use the older age.
Yes.
And milder cases. So if they had done in younger age, it would have been more devastating. So what does this conclusion tell you about? Would you use this in your patients?
No, we will need proper OI subset to study the role of denosumab to actually know whether or not we can accept it in our practice.
No, and if you study the answer, what they're saying that you're comparing drug A with drug B, and then you can say, okay, drug A has got side effects, but drug B can help in you getting those side effects better. So why should I use drug A? I should directly use drug B. So clearly they are saying it can be alleviated using zoledronic. So what they're trying to say, okay, use denosumab. If you have hypercalcemia, use zoledronic acid. So why should we use it in the first place is something which is clear. So I think this is a very, very clear study that this is a new way of thinking of it. The drug has been developed. Now they're trying to find its indications. This is a very well established drug in adult osteoporosis.
Yes.
But I think there are so many things. Probably there is not much pharmacokinetic dynamic data in children. Maybe it's not working for 6 months. So it's too premature a trial which has been done. So carry on with the further evaluation.
So this is a prospective open-label randomized controlled trial. The monitoring we did here using the DEXA scan and also the biochemical parameters of like calcium, alkaline phosphatase, PTH and phosphorus. And the population was taken was children and adolescents less than 18 years. Now, whether it is a generalizable or not, the children has been taken with children and adolescent at osteogenesis imperfecta, but there was no definite proven osteogenesis imperfecta in our inclusion criteria. And the intervention is feasible, but we need to be much more cautious in terms of this hypercalcemic episodes. Also, the dosing interval we using in the children. The major limitations I found in this study was that the dosing must be in the weight-based formulation, not be generalizable one. And the dose interval should be also be considered whether we can use 6 monthly dosing or a much longer dosing in that scenario.
So the basic concept is you give a high dose, doesn't matter, you are suppressing. A bit like GnRH analog. So they are going in that direction. So they're saying more will not cause any harm. So let's give a high dose. Like 60 milligrams is a huge dose. It's an adult dose. And 30 milligrams, let's say for a younger child, will be a big dose. So carry on.
And the study duration was not so longer, around 1 year of duration, and there was no frequent monitoring of blood calcium levels. So we may have missed some of the asymptomatic hypercalcemic episodes in between them also. So these are the limitations in this study. So it has significantly improved the bone mineral density as well as the vertebral morphometry. with some adverse effect. And right now, we think we should not recommend to use denosumab in the children until there is some much more important RCTs present in our hand.
I think that's a very good review, and I think this is a good message that everything new is not going to be something which would be followed in all the scenarios. Thank you, Alapan. And this really is an interesting molecule. A lot of work is being done. Now, recently, sclerostin agonist has already been approved in adults. It's available now. Denosumab is available. Now, it may take some time for it to come, but that will be an anabolic therapy. So that will be a positive way to go forward.